My name is Dr. Aaron Kaufman from CDC's Viral Special Pathogens branch. This presentation will cover important information for medical providers about hantavirus disease. At the end, you will be able to describe the risk factors, endemic areas, and incubation period of hantavirus infection, identify the clinical presentation and methods to identify a patient with hantavirus, and understand the parameters of clinical management and critical care for patients. I'll start with an overview of hantaviruses, then move on to the epidemiology of hantavirus disease in the United States, and then review the clinical presentation, laboratory testing, and treatment. Hantaviruses are a group of viruses that belong to the Bunyaviridae family. Rodents are the natural reservoir for these viruses. Hantaviruses are enveloped viruses, meaning that the virus is coated with a lipid membrane. This membrane makes hantaviruses very susceptible to disinfection and easily killed by household bleach, detergents, soap, and other disinfectants. Hantaviruses are divided into two groups, Old World and New World. Old World hantaviruses are primarily found in Europe and Asia. Infection can cause hemorrhagic fever with renal syndrome, or HFRS. Several pathogenic Old World hantaviruses have been identified, including pumalavirus, Hantavirus, Dobravavirus, and Solvirus. New World hantaviruses are primarily found in North, Central, and South America. Infection with New World hantaviruses can cause Hantavirus Pulmonary Syndrome, or HPS. Because of the profound cardiac features, HPS is also sometimes referred to as Hantavirus Cardiopulmonary Syndrome. Like Old World hantaviruses, several pathogenic strains of New World hantaviruses have been identified. In the Four Corners region, cases of hantavirus disease are due to infection with the New World hantavirus called sin nombre virus. I will now discuss the rodent host of hantavirus. In general, each hantavirus has a single primary rodent host species in which the virus is maintained. Hantavirus infection does not cause any apparent illness in the rodent. Infected rodents can shed the virus in saliva, urine, and feces for the length of their lives, but viral shedding is greatest 3 to 8 weeks after acute infection. In the United States, there are 4 pathogenic hantaviruses: sin nombre virus, New York virus, Black Creek Canal virus, and Bayou virus. Each of these pathogenic hantaviruses has a unique rodent reservoir. For sin nombre virus, the rodent reservoir is the deer mouse. Panel A of this graphic shows the geographic distribution of the deer mouse. As you can see, it is quite expansive and extends northward into the Yukon and Northwest Territories of Canada, the entire United States, sparing the southern regions of Texas, Louisiana, Alabama, Mississippi, Georgia, Florida, and North and South Carolinas, and southward through the central portions of Mexico, down to its border with Central America. The rodent reservoir for New York virus is the white-footed mouse. The geographic distribution of this rodent is shown in panel B and extends eastward from the Plain States and south into Mexico. The rodent reservoir for Black Creek Canal virus is the hispid cotton rat. The geographic distribution for this rodent is shown in panel C and covers the southeastern United States and Mexico. The rodent reservoir for Bayou virus is the rice rat. The geographic distribution for this rodent is shown in panel D and covers the southeastern United States from Texas to Florida and up the eastern coast of the United States as far as Virginia. Hantavirus is maintained within the rodent reservoir and is transmitted from rodent to rodent primarily through fighting and through bites and scratches from one infected animal to another. No other small mammals, such as voles, cats, and dogs, have ever been found to transmit hantavirus to people, nor have they been found to develop any clinical symptoms of hantavirus. Hantaviruses are not transmitted by mosquitoes, ticks, or any other arthropods. I will now talk about the epidemiology of hantavirus. This is a map of all the hantavirus pulmonary syndrome cases by state since 1993. As of January 2017, approximately 728 cases in 32 states have been reported. The highest incidence of hantavirus is in the western United States, particularly in New Mexico, Colorado, Arizona, and California. These 4 states account for almost half of the total cases reported in the U.S. The bars in this graph depict the annual number of hantavirus cases from 1993 through 2016 in the U.S. An average of 20 to 40 cases of hantavirus are reported each year. The number of cases has been known to vary based on seasonal weather patterns. It has been hypothesized that the increased precipitation associated with the El Niño phenomenon may lead to increased human hantavirus cases. Increased precipitation leads to increased vegetation, which leads to increased deer-mouse population densities, which increases the possibility of rodent-human interactions and increased disease transmission to humans. The 1993 through 1994 outbreak and the 1997 through 1998 outbreak followed El Niño years. The black line depicts the annual case fatality rate. Although the case fatality rate varies each year, it has been fairly consistent at 36%, except in 1993 when hantavirus was first described. This graph depicts reported hantavirus cases by month of symptom onset for the United States from 1975 to 2017. People can get infected with hantavirus by breathing in aerosolized virus. How does this happen? As we know, infected rodents shed hantavirus in their urine, saliva, and feces. When fresh rodent urine, droppings, or nesting material are stirred up, tiny droplets containing the virus can get into the air. People can also get infected through the bites of infected rodents. There is no human-to-human transmission of sin nombre virus. People who are exposed to rodents or rodent excreta are the ones at greatest risk for exposure to hantavirus. This includes people working in the agriculture industry, like farmers and ranchers, construction workers, and those working in forestry and park service. People who clean rodent-infested areas or live near rodent infestations are also at risk for exposure. Another risk factor is opening and cleaning previously unused buildings, such as cabins, sheds, barns, or other storage facilities where rodents can live and nest. People can also get exposed to hantavirus through recreational activities, such as camping and hiking, though the risk of exposure is much lower. I will now discuss the clinical presentation of hantavirus. The typical incubation period for hantavirus infection is 9 to 33 days, with a median of 14 to 17 days. During the 2012 sin nombre outbreak at Yosemite National Park, the incubation period ranged from 20 to 49 days, with a median of 30.5 days. The acute course of hantavirus disease can be broken into two stages. The first stage is the febrile prodrome. This lasts approximately 3 to 6 days, and patients may report fever, chills, malaise, back pain, myalgia, and headache. Although many of these patients seek medical evaluation, they are often diagnosed with a nonspecific viral syndrome, and hantavirus is not suspected. The second stage is the cardiopulmonary stage. The onset of this stage is very abrupt and characterized by a rapid onset of non-cardiogenic pulmonary edema, shortness of breath, cough, and hypoxia. Shortly after the onset of this phase, the patient may develop circulatory shock. Without adequate treatment, most deaths occur within 24 to 48 hours of the onset of this phase. Cases of hantavirus disease with mild or no pulmonary symptoms have been reported. One study described 4 laboratory-confirmed hantavirus infections in patients with mild or no pulmonary symptoms. All 4 patients reported high fever, headache, and myalgia. All 4 patients also demonstrated hemoconcentration, elevated white blood cell count with a left shift, and thrombocytopenia. Only 1 patient reported shortness of breath without evidence of pulmonary edema on chest X-ray. As of December 2016, 20 laboratory-confirmed non-pulmonary hantavirus infections have been reported in the United States. This represents 1% of all reported hantavirus cases. Clinicians at the University of New Mexico developed criteria observed from a peripheral blood smear that could be used to make a presumptive diagnosis of hantavirus during the cardiopulmonary phase. The peripheral blood smear screen is based on these 5 criteria: thrombocytopenia with a platelet count less than 150,000, elevated white blood cell count with a left shift, presence of immunoblasts, where immunoblasts account for greater than 10% of the lymphocyte population, a lack of toxic changes in neutrophils, and hemoconcentration. The clinical performance of this screening method was evaluated by looking at 11 years of hantavirus cases at the University of New Mexico. They found that the presence of 4 out of 5 criteria was 96% sensitive and 99% specific for hantavirus infection. They also found that out of the 5 criteria, thrombocytopenia was the most sensitive individual criterion, being present in more than 95% of patients and starting during the prodromal phase. The presence of increased immunoblasts had the greatest positive predictive value at 71%. Here is a graph describing the serial hematologic findings in a patient with severe Syndrome virus infection. The open circles depict hematocrit percentage, the closed circles depict the platelet count, the squares depict the immunoblast count, and the triangles depict the total white blood cell count. There is a precipitous drop in the platelet count, going down from approximately 120,000 to 50,000 over a 24-hour period. As the patient progresses through the cardiopulmonary phase, we can also see a rapidly rising white blood cell count, which eventually includes immunoblasts and a rapidly rising hematocrit. Hemoconcentration is most frequently seen in severe and fatal cases. As you can see, serial hematologic testing is important in order to identify potential indicators of worsening clinical disease. Here is a graphical depiction of the hantavirus illness course. First, there is a prodromal period where the patient will complain of fever and myalgia. At this stage, the platelet counts will start to decline. If you were to perform serologic testing, IgM and IgG antibodies would be positive at this stage. Virus titer is not included on this graph, but virus RNA is detectable by PCR during both the prodrome and the cardiopulmonary phases. It often declines as antibody levels increase. The febrile prodrome is followed by the cardiopulmonary phase, which is marked by cough, shortness of breath, and the development of bilateral pulmonary infiltrates. With the passage to the cardiopulmonary phase, you will see a rapid increase in white blood cell count with the left shift, increased presence of immunoblasts, and hemoconcentration. Patients with mild hantavirus pulmonary disease may only require supplemental oxygen, but those with severe disease will quickly progress to respiratory failure with or without circulatory shock. Patients who survive the cardiopulmonary phase will enter the diuretic phase. Clinical improvement is usually rapid, and many ventilator-dependent patients can be extubated within a day or two. Finally, the convalescent phase is characterized by weakness, fatigue, and poor exercise tolerance, and may persist for months or years. Currently, there is no rapid point-of-care diagnostic test for New World hantaviruses like Syndrome virus. Thrombocytopenia is seen early during the prodromal phase. A presumptive diagnosis may be made in the cardiopulmonary phase by evaluating the CBC with differential and blood smear using the 5 criteria described previously. Confirmatory diagnosis of hantavirus infection is made by testing with an enzyme-linked immunosorbent assay, or ELISA, capable of detecting IgM and IgG antibodies. These appear during the febrile prodrome and are 95 to 100% sensitive and specific for early hantavirus infection. Serological testing should not be used to screen for hantavirus infection in asymptomatic individuals because antibodies are not present during the incubation period. Confirmatory testing for hantavirus is available at some state health departments and at the CDC. False positive results have been reported with commercial hantavirus assays. For this reason, it is recommended that clinicians consult with their local or state public health authorities for assistance with test result interpretation and to arrange confirmatory hantavirus testing if indicated. So what are the keys in making the diagnosis of hantavirus disease? First, consider the disease in patients presenting with a febrile illness. Second, remember that infections can occur at any time of year. However, we do see peaks in the spring and summer. In Navajo Nation, we also see a peak in cases during the fall months. It is interesting that the peak in spring and summer is outside the typical influenza season. So if you are seeing a patient in the spring and summer with an influenza-like illness, consider hantavirus in your differential diagnosis. Another key to making the diagnosis is asking about exposure to rodents and rodent droppings and nests. You have to ask about rodents and rodent droppings because half of confirmed hantavirus cases do not report seeing rodents. If you're concerned about hantavirus, order a CBC with differential and a blood smear, and look for the 5 peripheral blood smear criteria, and repeat if necessary. Now, what should you do if you're unsure of the diagnosis? One thing you can do is consider repeating the CBC with differential and blood smear in 12 to 24 hours. In patients with hantavirus disease, platelet counts can decrease by more than 20,000 in a 12-hour period. Rising white blood cell count and increasing hemoconcentration can be seen in the cardiopulmonary phase. For further assistance, clinicians may consult their local or state health departments. Treatment of hantavirus disease is supportive. No antiviral drugs or immunotherapeutic agents have been found to be effective. There is no vaccine currently available. Inotropes should be administered early for hypotension. Avoid fluid resuscitation, as it may exacerbate pulmonary edema. Provide supplemental oxygen as needed. Take caution with intubation, as the effect of hemoconcentration in the setting of sedation and intubation can decrease venous return and has led to instances of cardiac arrest. Most importantly, transfer the patient immediately to a center capable of extracorporeal membrane oxygenation, or ECMO. So why do we use ECMO for hantavirus? First, hantavirus disease usually occurs in young, previously healthy adults. Second, hantavirus disease, while it can be quite severe, has a short duration of critical disease. Finally, the cardiopulmonary dysfunction seen in hantavirus disease is most likely due to circulating inflammatory mediators, and autopsies performed on fatal cases did not show significant tissue damage. A retrospective review of the medical records of 51 consecutive patients with severe hantavirus disease treated with ECMO at the University of New Mexico found that all these patients had a 100% predicted mortality prior to initiation of ECMO. The patients were divided into 2 groups. Group A consisted of 26 patients who were intubated when they became hypoxic and were not cannulated for ECMO until they became hemodynamically unstable. Group B consisted of 25 patients who had elective insertion of percutaneous vascular sheaths shortly after arrival in the hospital and were concurrently intubated and cannulated for ECMO when they became unstable. The overall survival rate was 66%. Survival in Group A was 53.9%, and survival in Group B was 80%. Early transfer to an ECMO center improves survival. Here is a list of references cited in this presentation. Thank you for your attention.